Hello, this is the physics lecture for December 16th, 2020. It's going to be on elasticity, and it's during the day that you have your practice exam for anatomy. So I wish you all the best. I hope everything goes well. Let's get into this lecture. So today we're going to talk a little bit more about elasticity, tension, and compression, kind of related to the human body, right? So elasticity is when an object is subjected to external forces. It can undergo changes in size, shape, or in both, right? Those changes depend upon the arrangement and bonding of the atoms in the material. For example, a spring can be stretched or compressed by an external force. I've got a nice little glasses cloth here, right? I can compress it up, and then it can return to its original shape, even though wrinkly, right? A weight hanging on the spring will stretch the spring. Additional weights stretch it further. The weights are removed. Hopefully the spring returns to its original length. Now, if it's been stretched for a long period of time, it may not. It'll lose its elasticity. The important part to remember is that elasticity is not the ability of something to stretch, but it's the ability of it to return to its original shape prior to the stretch. So when a batter hits a baseball, the bat temporarily changes the shape of the ball, right? An archer about to shoot an arrow first bends the bow, which then springs back to its original shape and allows the arrow to be released. The baseball and the bow are excellent examples of elastic objects. The body has elasticity, right? It's how much its body shape changes when a deforming force acts on it, how well it returns to its original shape when the force is removed. Even gaining and losing weight is an example of the body's elasticity. When you think about it, if you've seen somebody ever that has lost massive amounts of weight, 200-300 pounds, their body just doesn't look the same. That's because their skin has lost its viscoelasticity and no longer returns to its original shape. And a lot of times those patients end up needing some form of plastic surgery in order to return to a normal appearance. I had a friend back in Pennsylvania who lost 404 pounds. He was 6'02", and he got down to like 189 or something like that after gastric bypass. And he just had flaps of skin hanging on him because his body couldn't return to its normal shape. So he had to have massive surgery in order to fix it so he could look, quote, quote, normal. Clay, putty, dough, and lead don't return to the original shape when deformed, right? They kind of shape into whatever form you're forming. If you take cookie dough and you stretch it, it's not like that cookie dough is back into that tube that you got it out of for Pillsbury, right? Biscuits, another excellent example. If you ever make fresh buttermilk biscuits, when you're kneading it, right? You're kneading it, you're working the dough, and you're working the dough, and you're working the dough. It's not like the dough automatically goes back to its original shape. No, it stays in whatever shape you put it in, right? You cut the biscuits out, those biscuits stay cut. It's not like all of a sudden they're like, oh, let's reform back into the pile of dough. That would just be really weird. And we start worrying about, aliens that look like biscuit dough. So like I said, when we hang that weight on the spring, the weight applies a force to the string and stretches the spring. Twice the weight would cause twice the stretch, right? So let's say we hang a weight on this eyeglasses cleaner, right? As I start pulling on it, right? So here's one force, right? Now I'm pulling at two forces. Now I'm pulling at three. Now I'm pulling at four, right? So what I'm saying here is, as the spring stretches or as this thing stretches, the actual stretch is directly proportional to the applied force. So the more force I apply, the greater the stretch of the cloth, right? And then if I let it go, it should return to its original shape unless I've overstretched it. The relationship was noted in the mid-17th century by Robert Hooke, contemporary of Isaac Newton. It's called Hooke's law. An elastic material is stretched or compressed beyond a certain amount, it will not return to its original state and will remain distorted. The distance beyond which permanent distortion occurs is called the elastic limit. So the elastic limit is how far you can squish, stretch, compress, traction something before it no longer can stretch or compress any further, and it causes it to deform. So I got another example here. I got my little stress ball, right? My little stress ball, I can squeeze pretty hard. If I'd suddenly put that in a vise and start squeezing down, eventually it will hit greater than the stress limit and the elasticity of it, and it'll eventually pop. It had been stretched beyond its limit. It has violated Hooke's law. As therapists, we use the elastic principles of muscle and several stretching techniques to increase range of motion, right? All muscles and actually all connective tissue, which includes our bones and our tendons and our ligaments, display the properties of viscoelasticity. That means the combination of both elasticity and viscosity. This elasticity is the ability to return to its original shape, and viscosity is the ability of materials to resist a change in form to dampening shearing forces. Kind of think of like slow-moving molasses, right? Viscosity is often heard in terms when you're thinking of oil for your car, right? When you go to get oil for your car, I don't know if any of you still do this nowadays, you go to Walmart, you go to AutoZone, you go to O'Reilly's, and when you walk in, you see a wall of oil, and that oil all has a weight rating, right? It's like 5W30, 10W40, 4W70. There's all kinds of W blahs, right? That is the viscosity rating of the oil. The thicker the viscosity, right, the slower it's going to move. Now, that can be fine in an area like we have right now where it's really warm. Well, it's not really warm right now, but it's warmer than, if you look back where I'm from, Pennsylvania, they're looking at getting 32 inches of snow. So it's definitely warmer than there. But in our area, a heavier weight oil is fine, right? We could use something that's thicker and actually protects the engine a little bit better because, again, the thicker it is, the more it adheres to the surfaces, the more it's going to protect the surface inside your engine. The thinner the oil, the easier it is to run. It's going to become more water-like, right? Now, that can be useful in an area like where I'm from in Pennsylvania, where it's cold. This is very common in the Pennsylvania region, that if you drive a truck like I drive, you use two different weights of oil. You use a winter weight oil and you use a summer weight oil. The winter weight oil is for during times of obviously winter. You want a thinner viscosity oil because as cold happens, that viscosity is going to kind of clamp down. It's going to actually get thicker. Whereas if you have a really thick viscosity oil and it gets thicker, it kind of becomes sludge-like and doesn't allow it to flow in the engine. So viscosity is kind of that ability to resist shearing force, right? Viscosity itself is both time dependent and rate dependent, meaning that, you know, there's a certain amount of time of how much it can resist stuff. And there's also rate dependent, how fast something goes. So in your car, right? And I keep relating it back to the car just because the car makes it easy. Viscosity itself is time dependent, meaning that oil has a certain half-life. And you know this, right? Everyone has to change. Okay, for those of you that don't know this, you do have to change the oil in your car, right? Maybe you get it done by the dealership. I'm sorry. Maybe you do it yourself. Congratulations. But over time, that oil is going to break down. Same thing happens in the human body, right? Our viscoelastic layers slowly break down and they will stop resisting that shearing force over time, right? That's why patients need hip replacements. That's why patients need knee replacements. It's also rate dependent. So in your car, if you juice the gas and you suddenly take off, that puts a lot of shear force on the engine. And if your oil is already at its kind of time-dependent time period to be changed, you can actually damage your engine because the oil will no longer protect that. The body's the same way. Let's say you're lifting way too much weight and you're trying to get swole, but you lift too much weight. Well, now that viscosity is no longer able to protect maybe that joint. You may end up with some damage or some cracking of some bones because of it, right? So it is this time and rate dependent. Viscoelastic materials, in contrast to purely elastic materials, have time-dependent properties. Slower rates of stress produce greater amounts of strain or elongation, whereas faster rates of stress produce much smaller elongation. What does this mean? Well, this is when we're talking about the human body, talking about the difference between slow rate or low and slow stretching versus ballistic stretching, right? So low and slow, if I'm going to stretch my wrist out, I'm going to stretch my wrist like this. I'm going to hold it. Right? So what I'm doing is I'm stretching out the flexors of my hand, right? Because this is my palmar surface of my hand. So these are my flexors, my hands that pull this way. So as I stretch them, I can sit here and hold 30, 29, 28, 27, 26. That would be a slow and low stretch. I'm actually going to produce a greater amount of elongation with a slow and low stretch versus a ballistic stretching. So ballistic stretching, I'd be sitting here going like this, right? Rapidly doing it. Now, if you look at the studies, and we'll talk about this in Therex 1, Ballistic stretching can create a more rapid stretch, meaning that if you need a quick elongation of your muscles, ballistic stretching may be the way to go. Where slow and low rate stretching has some science to show that it produces a longer stretch, meaning that your effects from that stretch will last longer and longer. To play into this, we have this thing called the creep phenomenon. The creep phenomenon is a gradual increase in tissue length occurs while maintaining a constant stress. Again, slow and low. The more we kind of relax and pull that stretch out, the longer these muscles are going to get to the point where they can stretch. Why could that be important? Well, let's think about somebody that's got a spinal cord injury, right? So now I got a spinal cord injury. What's going to happen to a patient, especially if they have a high level spinal cord injury, is everything's eventually going to kind of come into that center, and they're going to get almost fetal position like, because that's what the body's going to do, is they're going to pull into center. We're all naturally kind of designed that way. We pull into the core. Think about it when you're a baby. You're in here like this, right? Well, that's the same thing's going to happen to the hand. Over time, if we don't use our hands will kind of curl up and gnarl up like this. And you may see that in patients that have something like rheumatoid arthritis or something to that effect. Their hands kind of gnarl up. Well, in order to overcome that, we're going to have to stretch them back out, right? So we have to kind of stretch them at a slow and low stress in order to allow them to become more normalized. So then we got this stress relaxation phenomenon. It's a contrast to the creep phenomenon. Viscoelastic materials may experience a constant strain under an equilibrium is reached, and the stress equals zero, resulting in relaxation of the tissue. Okay, that's a lot of words. What does this say? It says that, as a muscle itself, if you just kind of let it sit, it has the ability to kind of elongate on its own with relaxation, right? There is an equilibrium. If we just let our arms kind of go down, there is an equilibrium that they'll eventually reach. Now, if we are tight, it may stop here, right? At that point, it may need some stress to go past where it's stuck at. But we do have this stress relaxation phenomenon where we can actually stretch the muscles just by relaxing. So here's kind of an idea of it, right? So here we have somebody stretching the hamstrings out. Constant force applied by the therapist. As that elongation occurs with the creep phenomenon, it'll eventually kind of plateau out. In the other one, which we have the forced relaxation, they're just holding the leg there. They're not allowing that leg to kind of stretch. They're not pushing into it. So as they hold that in that position, there'll be a slow relaxation of the muscle, which will allow a little bit of stretch to occur. That can be really important when we do stuff like splinting, right? Because we may want to splint somebody that's got a hand contracture, or maybe even a biceps contracture. Maybe they had a shoulder injury and they got put in that full arm cast, right? And now they come out of it and their arm's stuck like this. Well, we may splint them with splints where they're progressively lengthening the arm just from relaxation. And they'll still get a relaxation out of it, and they'll still get an extension out of it, but it just will take time different, right? In addition to the stress and rate of stress applied, temperature also affects connectivity extensibility, right? So what that's saying is that our rate of stretch not only applies to what we're putting on stress-wise, but also the temperature, right? We know that higher temperatures affect the viscoelastic properties of connective tissue and increase the rate of creep phenomenon. So 37 to 40 degrees Celsius is ideal. Well, what does this mean? Increased temperature in muscles can occur from both internal and external factors. So we can do things to increase the temperature of the muscles. But hot packs, ultrasound, diathermy, fluidotherapy, contrast baths, ultraviolet, and low-level laser therapy can work. We can also do internal by warming up the patient, putting them on a treadmill, putting them on a bike. Also, feverish can increase the pyrexia, can increase the rate of creep phenomenon. Think about this with yoga, right? We've all seen and joked around or maybe not all joked, but we've all seen the phenomena with this hot yoga, right? And the reason that you do hot yoga is the theory is that if the room is really, really warm, the body will be really, really, really warm and more responsive to the stretches of the yoga. There is science behind that. I don't know. I've done it once. I will never do it again. It was the most uncomfortable experience I've ever done, mainly because I don't like heat. So one of the best ways to stretch out a connective tissue structure is to heat it up and use a large load over a long period of time to produce the creep phenomenon. So basically, warm it up and low and slow stretching. Low temperatures will overall reduce the effect of creep phenomenon. This can be critical. So what are some conditions that patients may have that might prevent our limited option from warming up? Well, what if the patient has something like MS, right? We know that MS, we can't actually do that type of activity with it, because MS, when we heat up the body of a patient that has MS, it actually can have a negative effect on the patient. So we know that we don't want to heat them up too much because it causes problems. What if they're severely pyrexic or severely feverish? We definitely don't want to do it then either, because if they're severely feverish, that can cause even further problems, because that could cause the fever to actually get worse. There are other conditions, though, where we've got to watch the heat with the patient. Cancer. What if I'm trying to stretch my arm out, but the patient's got shoulder cancer, a cancerous cell in the shoulder, something like that? We don't want to add heat to those patients, because we add heat, it can actually increase the spread of cancer. So we definitely don't want to do that. So there are some options where we may not be able to warm the patient up, and we may have to go with what we've got. All right, so sorry, my computer was freezing up on me there. So when something is pulled on, stretched, it's said to be on tension, right? When it's squished or pushed in, it's said to be in compression. So tension is when we pull it like this, right? Squishing it is compression. So if you bend or rule or any stick, the outer curved part is in tension, the inner curved part is in compression. So let's see what I got here. What I have in my drawer of magical stuff that I can pull out to. All right, so we got a little rubber band thing here, right? So the side on the outside of this is actually being lengthened slightly. You can see it because it goes a further distance. The inside is actually being shortened, right? So let me get a pen so I can have something to point with. Right, so the outside of this little rubber band thing is stretched out. The inside is slightly shortened. So that means the outside of that curved item is on tension, it's being stretched. The inside of it is on compression, it's being squished, right? Tension causes things to get longer and thinner, whereas compression causes things to get shorter and wider, right? So when I squish this, it gets shorter and wider. When I pull it apart, it gets longer and thinner. This is not obvious for most rigid materials because the lengthening or shortening is very small. So like if I do the same thing to a steel beam, it's really hard to see. But even if you were able to look, like if you're in a skyscraper and we're able to look underneath the floors, you would be able to see the beams underneath slightly sagging and moving as the weight inside that floor changes. And steel is an excellent elastic material because it will withstand large forces and return to its original shape and size. Because of its strength and elastic properties, it's used not only to make springs, but construction girders, right? We use steel in almost all of our buildings that we build. We have vertical girders are used in the construction of tall buildings, right? And they only go slight compression. They're just made to form up the outside of the building, right? Typical 25-meter long vertical steel girders used in a high-rise construction is compressed only about 1 millimeter. And that's only when it supports a 10-ton load. Think about that. All those girders supporting those buildings, even if they're under a 10-ton load, they only compress 1 millimeter. I can't even show that with my fingers. That means a 70 to an 80-story building can compress a huge steel column at the base by some 2.5 centimeters or a full inch. To me, that blows my mind that those base girders are being compressed by almost a full inch. Right? More deformation occurs when the girders are used horizontally, right? Where tendency to sag as under heavy loads is greater. When a horizontal beam is supported on one end or both ends, it undergoes both tension and compression from its weight. and the load it can support, right? If we have a horizontal beam that's supported at one end, it's called a cantilever, right? So in this case up here in the top, this is an example of a cantilever, right? So it's supported on this end, but the beam kind of hangs out like this. If we put a weight out on this end, this top part of the beam is then going to end up getting stretched out. The bottom part of the beam is actually going to compress together slightly, right? It's going to sag because of its own weight and the load it supports on the end. A little thought, they'll show the top part of the beam slightly stretched and the bottom part kind of squished together, right? And somewhere between the top and the bottom, there's a region where nothing happens, in which there's neither tension nor compression. There is a neutral layer where nothing occurs, this kind of middle layer here. And so that allows that beam then to return to its original shape when we pull this load off. Then we have a horizontal beam known as a simple beam that's supported on both ends and carries load in the middle. Here there's compression at the top of the beam, tension in the bottom. So at the top of the beam for this one, because that top of the beam is kind of collapsing in, the top of the beam is actually getting compressed. The bottom of the beam is actually being spread out because it's lengthening, right? There is still that neutral layer that nothing occurs, and that's what allows it to eventually return to its original shape when the load is removed. So a cantilever is that one up top here where we have a single beam supported on one end, and then a simple beam is one that's supported on both ends. When I think of simple beam, I think of balance beam, right? When I think of cantilever, I think of a diving board, right? Diving board is an excellent example of a cantilever. So when you're on a balance beam, you're walking across it. As you move between two supports, the center of that beam will sag slightly, right? That top portion of the beam is getting compressed. The bottom portion of the beam is getting stretched. It's the opposite is if you're on the top of a diving board. When you're at the end of the diving board, the top portion of that diving board is getting stretched. The bottom part is getting compressed. So we use tension and compression frequently in physical therapy with regards to joint end feels and testing out joints. So a lot of times when we move a joint in a specific position, maybe I'm moving my arm into abduction, right? We're going to be testing to see what it feels like. We're looking to see what does it feel? How does the end of that joint feel, right? So if I take my wrist and I pull it back, I get a really firm kind of rubbery response, right? Because if I lift off, my hand kind of snaps back, right? So I pull, bang, bang. So I get a little bit of a rubbery response from that. You can also end up with capsular end feels. This is where it's firm and it kind of locks up on you. There's only one part of the body where you should get a bony end feel, and that's in the elbow. And we'll cover these more in depth next semester with kinesiology, so don't freak out totally yet. Soft end feels, where we get a softer, mushy end feel. So maybe when you squeeze your elbow up into elbow flexion because you have those soft tissues approximating. Or more importantly, when you bend way over, eventually your belly kind of gets in the way of you bending too much farther over, unless you're really, really skinny, then you can touch your toes, unlike me. Firm again is kind of that where you get the resistance of the muscle. And then empty. We have this empty end feel where a patient, you can't get to that end feel. A lot of times this is due to pain. So this is where you're moving the patient in shoulder flexion. They're like, ow, ow, stop. Well, at that point, we don't know what the end feel actually feels like. So we call that an empty end feel. So let's think about some things when we're talking about different muscles, right? So let's think. So if you put some muscles on full tension, right, meaning full lengthening, that means some muscle elsewhere in the body is going to have to be compressed. So let's think about it from the shoulder flexors portion, right? So if we stretch out the shoulder flexors, well, that means the shoulder extensors. That's supposed to be a straight line. That was a really good straight line, Mr. McKeever. We'll just write out extensors. The shoulder extensors, right, are being compressed. So if I'm stretching my shoulder flexors way back, my shoulder extensors are being kind of compressed. Biceps. So if I stretch out my biceps all the way, well, that means that my triceps are going to be compressed. Wrist flexors, well, that makes sense. Wrist extensors, right? Finger extensors, well, then we get the finger flexors. Trunk flexors, extensors. What about the hamstrings? If we stretch the hamstrings out, what's getting compressed? The quads. Tibialis anterior. Tibialis anterior's job is dorsiflexion. Well, the muscle that resists that, or the group of muscles that resist that, are the triceps surae, you know, the gastroc and the soleus. So they would be put on stretch. If you stretch your toe extensors, toe flexors are getting compressed. Capital extensors, the muscles allow you to extend back. Well, the capital flexors are being compressed if you're stretching them. Sternocleidomastoid is a unique one. Typically, if you put one sternocleidomastoid on stretch, the other sternocleidomastoid is on compression, because sternocleidomastoid's job is to rotate the head and laterally flex it, right? So if I'm stretching this side's compressed. In the human body, there's not really a good example. So it says, are there any muscles that you push to full excursion will not have a muscle shortening? Not really. Most muscles themselves, when they're pushed to full excursion, have a muscle opposing it that is shortening. That's the way the body is designed. And we'll talk about the theory of reciprocal inhibition in kinesiology. And we'll talk about how that comes into play with this, because what that does is that helps us understand, well, one muscle is getting stretched out, the other muscle is going to go ahead and get compressed and shortened. So what do we use compression and traction forces in physical therapy? Well, we use compression, also known as approximation, when dealing with joints, and traction frequently when dealing with pain. We can do things like mechanical versus manual tractions, right? So you've seen mechanical traction probably in the clinic where they strap people into those tables and the machine slowly pulls and stretches their spine out. Well, that traction unit that you've seen also has devices for stretching the arms out, for stretching the legs out, even for stretching the neck out, right? That's great. Some clinicians don't like mechanical traction, prefer manual traction. And manual traction is where the clinician does the traction. This can be really important in patients that maybe are such as pregnant patients, because pregnant patients can't go on mechanical traction due to a hormone that gets released in their body called relaxin. The relaxin itself causes their joints to become very hypermobile. So if you put them on a mechanical traction unit, you can actually injure them. But that doesn't mean that mommy who's pregnant doesn't have low back pain. At that point, we may do manual traction if the therapist is trained on it. Joint approximation, right? If we have an injured joint, let's say we sprained our ankle and we did an inversion sprain, which is the most common sprain that can occur. If we had an inversion sprain, we may position the joint in what's called the position of comfort, right? Which is the opposite of the direction it went. So if I invertedly sprain my ankle, that means all this on the outside is stretched. I want to put that on relaxation. So I'm going to go the opposite. And I'm going to approximate that joint in order to relieve pain. This comes back into this open packed and closed packed position, which we talked about really briefly before. Open packed position is the joint position in which the contact between the articulating surfaces is minimal. So that literally says in the open packed position, the joint is easily moved within the joint surface. So like think of the knee. And let's talk about closed packed real quick, then we'll talk about it. So closed packed is where the joint position in which the contact between the articulating surface is maximal. So we've got the knee, right? If we are in full extension, right, that tibial plateau is locked in to those femoral condyles. That point, that knee is in closed packed position. But even if we go into full flexion, there's another kind of locking that occurs. And at that point, it's a reverse closed packed. Anyway, we're not going to talk about that, but that's still not quite an open packed position. But now, what if I go about 3/4 of the way between it? So now I'm here. Now my tibia is slightly off my femur. My femur is not locked in. I'm now in an open pack position where I can mobilize the joint. And we'll talk a lot about mobilization and kinesiology with how do we mobilize joints in order to help with what we call capsular end feels. But in order to stabilize a joint, we put them in closed pack position. In order to mobilize a joint, we put them in open packed position. So closed pack, stabilization, open pack, mobilization. Closed pack, stabilization, open pack, mobilization. There might be a reason why I'm repeating that multiple times. So we use compression a lot for swelling, right? But in order to determine the maximal benefit, we must determine where the swelling is coming from. Is it an injury? Is it lymphedema, right? And then the treatment protocol will vary based upon the diagnosis as well as the compression rate. Usually the more involved the lymphatic system, the lower the compression will be. Well, and why do you think that is? Well, you've learned in anatomy, or hopefully you've learned in anatomy, the lymphatic system is a very shallow system, meaning it's not very deep in the body. So if I've got something that's really shallow on this ball and I put a lot of pressure on it, I've now squished it, right? So now that means that system is now being compressed, which may cause the swelling to get worse. We may just want a slight compression on it in order to help the pumping mechanism get the stuff back. With the lymphatics, the majority of the pumping is going to occur through movement. So that's why a lot of patients that have swelling get a lot of swelling when they're not moving. Think about it. Have any of you ever gotten on a plane? Maybe a cross-country plane, like it's happened to me before. You fly across to go, I was going to Boston. And I got off the plane, and man, I got to my hotel room, and my feet were swollen. Right? Well, why was it? Because I didn't really move for 6 to 8 hours or whatever it was. I was stuck on a plane. I didn't have a pumping mechanism helping me work some of that fluid out. Plus, my legs were in a dependent position. They were kind of hanging down, right? So all the fluid just kind of collected there via gravity. So how do you help that? Get up and move, right? So I went down and ran on the treadmill a little bit, and that kind of helped it a little bit get back to a normal size, right? It was a little uncomfortable too, because when your feet are swollen, they don't feel the best. So we talk about this. If we have an acute injury, maybe you do sprain your ankle. One of the things we'll talk about is doing rest with the ankle. Rest, ice, compression, and elevation. Well, the rest is going to be so that we don't re-injure it. The ice is because the ice will help relieve the pain. The compression is to help relieve the swelling, and the elevation is to help relieve the swelling even further. So we actually reverse the gravity so the swelling comes back to the body. So let's say I sprain my wrist. If I can elevate my wrist like this, I can help return that swelling back to the heart versus leaving it in the area that it's actually at. So why would swelling be bad for the body? Well, it increases the distance nutrients and oxygen have to travel, right? So the more resistance out there, the less likely the nutrients are there to get there. Equally, if it takes longer distance to reach tissue, it takes longer to empty out the area of debris, leading to debris accumulation, right? With this increase in debris, it further makes the area more difficult to get to and clean out, which further increases the overall accumulation and swelling. And this can lead to cellular death and wounds. So it's very common for patients that might have severe lymphedema to start developing, cellulitis or pressure injuries on the outside of their body, right? The other thing is it restricts overall range of motion, which reduces your movement, which then increases your swelling anyway. When you think of swelling, it's like forming the body's natural cast. So you injure your ankle and your ankle puffs up and swells up. Well, why does it swell up? The body is saying, stop it. Don't put weight on this joint anymore. It's injured, right? So that's kind of the goal of it. The joint itself is kind of protecting itself. Now, once you have that, it further separates the joint structure from one another, leading to potential connective tissue damage as well. Secondary complications include infection, muscle atrophy, joint contractures, interstitial fibrosis, RSD. There's all kinds of problems that go along with that. And we'll talk about all of those in patho. So thinking back to tissue's elasticity, what other modalities might be useful when pairing with compression? Well, we talked about ice. Ice is really good for relieving pain, right? Compressive forces, what kind of compressive forces might we use? Well, when we think about compressive forces, a lot of times what we think about is forces that are going to compress up to body's diastolic blood pressure. Most diastolic blood pressures are about 80 millimeters of mercury. So what unit do we use to measure compression? Well, we're going to use millimeters of mercury. We may use bars in certain areas, right? Stuff like that. Depends upon what we're using. PSI can be used. This comes into play with patients that are now they're doing blood flow restriction as well, which we'll talk about later. I don't even want to get into that right now because that could get me on a 40-minute tangent, and I'm going to be wrapping up this lecture shortly. So all of that comes into play when we do this compression. So compression, again, is where we move the joint surfaces together. That means we're putting them in closed pack position, which is used for stabilization. Traction, or pulling them apart, or tensioning, is where we separate those joint spaces. We move them into open pack position. It is used for mobilization. And that is it for this lecture. You survived this. This is a short lecture. We got more coming up. I'm excited to do some of the stuff coming up that I've got planned, which leads to more physical therapy type stuff. But I hope this lecture was informative. I try to make this one a little bit short because I know you guys are preparing for your anatomy exam, so I don't want you totally freaking out about this. Good luck in studying. If I can help at all, please contact me, and have a great day.